Today we have Marc Lipsitch from the Harvard School of Public Health, Department of Epidemiology. We're very, very lucky to have him. He's saying no to everybody else except us, so that's great. Thanks, Marc. So I'll start by saying that we usually do 30 minutes, and today we might go a little over because Marc has agreed to that, and also I am seeing already a lot of questions coming in, so we might be a little bit longer than usual. But with that said, let me just shut up and start. So my first question is same I asked our previous previous speaker, and is that during the pandemic it has been challenging for me and others, I'm sure, to stay informed, in part because it's hard to figure out who is an actual expert. And several of the people that speak with authority and confidence, at least I have some of them I've eventually decided are simply just overconfident and not necessarily that knowledgeable. So you're one of the few people that I've continued to read and follow because I find your writing and tweeting very informative. So my first question is, what makes you an expert? And also, how do you determine who's an expert?
That's a good question. I think that the quality that unites most of the people that I see as experts is a lot of experience with infectious disease outbreaks. And so, for example, our research group has been working on this kind of problem since 2003 with SARS, and then during the period when everyone was worried about a bird flu outbreak, we're working on historical 1918 data, and then the 2009 pandemic. And you learn a lot by actually working through the data. And one of the things you learn is that, especially in real time, less so after the fact, but especially in real time, the data are, the way the data is generated is never quite what you would hope it would be. And you can say that especially in this pandemic, with very rapidly changing testing rates and all sorts of other things. So I think, to me, one of the crucial delimiters between experts and people who are overconfident is an appropriate regard for where the data come from, and a level of interpretation that matches that. Whereas some people who are newer to the game or have expertise in quantitative fields where you are more used to relying on measurements, say economics or computer science, where the instruments are not being built while you're trying to use them to measure things. Those people, if they haven't seen what's different about infectious diseases, sometimes take the data too literally and then get misled.
Mm-hmm. Yeah, so I'll say that part of what impresses me about your approach is that you embrace uncertainty and model misspecification as a possibility. So as a statistician, we don't see enough of that. I appreciate that, and I don't think there's enough of it. So I think that's somewhat related to what you were saying. So
yeah, I mean, I think that's exactly right. That I think it's important to realize the limitations of the data, and one of the things we try to teach our trainees is that that nobody really cares what's true about your data. They care what's true about the world, and insofar as your data and your analysis of them shed light on how the world works, that's great. But your data set is not of intrinsic interest until you prove it is, and exclude alternative explanations for whatever it is you're finding compared to the one that you think. So I think that's sort of how all of us in the CCDD, Center for Communicable Disease Dynamics, try to think and try to train our trainees. And I think also as a communication strategy, it's important to embrace uncertainty because then people trust you when you say something is true, that you are certain about something.
Mm-hmm.
And
that's a very good point.
And I think, in climate change, there's debate about how much it's gonna warm, but there's not very much debate about the fact that it's going to warm to a degree that's threatening. And so distinguishing the uncertainty from the certainty is more plausible if you admit that some things are not exactly known.
That's right. I agree 100%. And I also note that alarmism and sensationalism gets people attention. So there's a strong attraction to say things that are scary and doomsday, or the opposite, or just saying or being completely dismissive. So you see that the press seems to go for that, and then some academics seem to this wanting the attention, go after those kinds of statements and being very sure that gets you the attention from the media, for example.
Yeah. Well, I think in public health, we have that responsibility of raising alarms that we hope are will be made false by our actions, or in some cases will be, there's a reasonable chance of something terrible happening, so we need to take action against it. And maybe it doesn't happen this time, either because we stop it or because it wasn't going to happen. But I think it is important to be alarmist in the sense of saying there's a chance of something bad happening. And that's why I was very early on saying there's a good chance that this is a pandemic before the evidence was perfectly clear. So I think we have to embrace that form of uncertainty of saying, if something really bad is potentially happening, we need to take action as if it's happening, because the consequences of not are worse than the consequences of overreacting.
Yeah, it's a tricky balance. All right, so you've been critical of the Trump administration's approach to the pandemic, and you say that we've been lacking a national strategy. So could you say a little bit about what you think the worst mistakes were and what could have been done differently?
Yeah, I mean, there were really a lot, but starting from dismantling aspects of our public health response before the pandemic, including the White House group that was focused on pandemics and some of the support that the CDC needed but didn't get early before all this started. Then once the intelligence reports were coming in from China, and you didn't have to have classified information, you could also just read the newspaper or read ProMed and other sources. The response seemed to be two things. One was deny the size of the problem, to say it's going to be okay, and the second was close the borders, or try to close the borders, which turned out to be ineffectual. And I was actually in favor of closing the borders as one tactic in a broader strategy of buying time to build up our reserves to deal with this potential problem. At that time, it wasn't yet a problem. And most of my friends thought this wasn't going to work, it's not going to help. And they turned out to be right. It didn't help very much, but it probably would have helped a little bit had we used the time that we bought by reducing the inflow of cases to stockpile PPE, figure out a strategy for producing more, figure out a strategy for producing more test kits, make a better test kit, deal with the state-to-state competition for ventilators. This is like a war. There are many fronts on which you have to fight a pandemic, and preparing for those means that you have somebody who has to coordinate. You have to have somebody to coordinate all those different sort of types of action, and try to reduce inefficiencies in each of them. And you also have to be very open about the level of the threat. And Singapore's prime minister, for example, very, very early on went on Facebook and said, here's what we're facing. I'm afraid it's going to get out of control. We're going to do our best to keep it under control. We may fail. Here's what's going to happen. And that was a public strategy that made sense to people. And meanwhile, our president was just saying, and his advisors were just saying it's not a problem, and then casting blame every time something turned out to go wrong. So you need coordination.
So let me see if I can get a little bit more detail. So with testing, let's focus on testing. So you're an advocate, and most knowledgeable people are advocates that we should do more testing. Now, what I want to hear a little bit about is what is it exactly that you do with that information? And how do you implement it? What would be a strategy that you would favor with details, like not just let's test and know, like what once you know, then what?
Yeah. Well, I think the first thing is that if you have sufficient testing to not just test those in the hospital who you need to diagnose and figure out the treatment and the protection of the healthcare workers, but actually to do some sort of surveillance testing, which could be of delivering mothers like they're doing in New York City, could be of people who are coming into healthcare for other reasons, as they do several places, could be other types of random quasi-random sampling. Then you have a picture of the trajectory of the epidemic. And all of these very costly and unpleasant control measures that we are living under need to be put in place to try to stop things from getting out of control, and then lightened in a way that ensures that they aren't getting back out of control. And if you don't have sufficient surveillance testing, then you really can't tell that.
I see. So it's more, it helps us plan where to lock down and where not necessarily to do it. I think that kind of.
I think local, yes, in time and space. So I think that's one of the big aspects. I think a second piece is, if you get the numbers of cases down well below where they are here, but where they are in Korea and in some parts of Europe, for example, after a long period of lockdown, then you can begin to use testing effectively for case-based interventions like testing and tracing and quarantining of contacts.
Mm-hmm.
I don't think that strategy is feasible at the levels of cases we have in most parts of the US, maybe all of the US right now, at least at the state level. There are probably pockets of counties that are low enough, but each state, I think, has more cases than it can really do that with. But
Got it.
So there's a synergy between the lockdown type measures and the then case-based interventions, which are very good when they're applied sort of artisanally, and not very good when they're trying to deal with the whole a large raging epidemic.
Yeah, interesting. So yeah, I'm going to ask you now a first one from the audience. So it relates to this op-ed by Feinberg, Kim, and Schlein, came out in the New York Times.
Yeah.
And it was, they were, I mean, you know what it is, but I'll tell the audience. It was this paper using data from Wuhan that the lockdown was not enough and that we would even need to separate families. I remember reading that and thinking that it was crazy, but I wasn't an expert and they were. So I wonder what you have to say about that op-ed.
Yeah, I tweeted it. I sent a response to the Times, which was not printed, and put it into tweets instead afterwards.
I missed those, sorry.
With Jonathan Grad and Caroline Bucky, colleagues at the CCDD. There are a number of problems with that recommendation, and Harvey Feinberg is one of the people I admire most. He used to be our dean before I arrived, and is really a thoughtful person in many areas of public health. And I told him before I responded publicly how much strongly I disagreed with it. But I think in this case, the group of the three of them were wrong, both on the science and on the policy. On the science, the paper that was published in JAMA by Pan and colleagues, including at least one colleague from Harvard School of Public Health, just used an inappropriate method for trying to estimate the reproduction number. And as a consequence, and we've put a comment on the JAMA website about this, as a consequence, got wrong the timing of when the reproduction number went below 1 in Wuhan.
Can I interrupt you and ask you, did that paper have any experts that you consider experts in infectious diseases?
I don't know most of the authors because most of them are in Chinese institutions that I just don't know. So I don't know the answer to that because there are a lot of people in China doing very good work that I don't know. So I don't.
Okay, sorry, go ahead.
I don't know the answer to that. But I will say that the issue of how to estimate the time varying reproduction number, which is a technical issue, but is just trying to figure out at what point does the epidemic stop increasing and start decreasing. there's ongoing discussion about how to do that. We have a preprint that we're working on putting together that summarizes all of what people have been figuring out over the course of this epidemic. Most of these technical issues don't matter that much in normal times, but if you're trying to figure out, was it 1 week or the week before that something happened, then a few days of error in your timing can be very important to your outcome.
Interesting.
So I
Yeah,
thought the science was wrong, and furthermore that the policy description of what other countries, Korea and Singapore, had done was also not fully accurate in that op-ed, and that the prescription of doing the same thing in the United States was further wrong because it was scientifically not based on much, and to violate civil liberties by separating families as they proposed to do in the service of a scientifically unjustified control measure seems like the worst of both worlds.
So do you think that as a community, the scientists came out looking okay there? Because I guess most of us, well, I should include myself, but most experts said this is not, we don't agree with this. It's just one group.
Yeah, I don't know. I don't know if the scientific community spoke with one voice or not. I think part of what's been really interesting about this pandemic is both the sort of bringing together of scientific voices, but like in my own experience, I've been working with different people that I hadn't worked with before, and communicating with them. But also many of the people that I most value as colleagues, just we've all been so busy and we haven't talked almost at all. So
Yeah.
the scientific community is both being brought together and fragmented in complicated ways right now, at least in my experience.
I apologize for taking so long to answer your email, Mark. So, so that paper that you just talked about, I remember it had this, something that caught my attention, is that the interventions were estimated to prevent 94% of infections, which, you know, didn't sound right, but whatever. I mean, that was a while ago. But the point I want to make now, this is maybe the first sort of data science-y question, is that I actually asked for the code and data for that paper when I saw it. I thought it was worth taking a look. I didn't get it, and my question to you is, what are your thoughts on this this new approach to maybe making publications come with data and code? Should we trust papers that don't make data and code available? I know we can't always make the data available, but if we can, and if it's not made available, what do you think about that? What are your thoughts on requiring data and code to be public?
Yeah, in principle, I'm completely in favor of it for the reasons you described. And we also requested the data, not the code, but the data. We probably should have requested the code, and ended up having to digitize it because we were told it wasn't publicly available. Mm. But luckily there were good figures in the paper. I think in principle, it absolutely should be required. I do think that there will be a cost in the sense that making code available that's usable is a time-consuming activity, and I think people will write fewer papers if they have to write papers that are that meet that high standard. And it's not always worthwhile. It's sometimes, and you don't know if it's going to be worthwhile. So I think there's a real trade-off, and maybe this is sort of acknowledging model uncertainty. I think in principle, it's a really good idea because we all need to be able to figure out what other people did, especially with high consequence publications. And I also think it will slow down science.
Yeah, I'm with you on this one. I think we sometimes people from my side that we don't we're not aware of how much things would slow down if we had this requirement. Now, at the same time, we are trying to educate people to make it easier to write reproducible code and all this, and things are getting better. There's a lot of new technologies coming out, new software packages and approaches that make it easier to do this.
Yeah.
Yeah,
I think it's going to be a generational thing to a degree. I mean, and I partly say that to let myself off the hook as an old guy. But certainly the 25-year-olds seem to be much more both in favor of open science and open data, and also better at it.
We are. So, all right. So now let's. I have a few questions here where I'm going to try to get to all of them, but now actually maybe showing some code and data. So I want to talk a little bit about the mechanistic models, and show data and get your thoughts on why we're seeing what we're seeing. So let me share my screen real quick, and I'm going to be using one of the tools that's good for reproducible research. It's our studio. Can you see it?
Yeah.
Okay. So this is data that the New York Times is making available. So I'm going to show you the data, daily deaths for our New York. All right, what the heck is going on? All right, there you go. So there's New York. Right. So these are deaths per million, and you see these dots are the actual reported data. The date is on the x-axis, and then the curve is a curve I fit where I include a weekday effect that isn't shown here, but it is included in the calculation of that curve to avoid weekend effects moving it around. And it's a Poisson with this over dispersion so that the variability can be captured. So you can see that the curve follows the points pretty well, and then there's a standard error curve around it. That's New York, but that's not really the main point. Is I want you to see the shape. I think you've seen this before, and then this is Italy. Here's Spain, which has a huge outlier down here, which I'm going to get rid of. And there's Spain. So if we look at them again, you can see that the shape is similar, right? I'm sure you've seen that. So when I then look at the differential equations for the SIR models and other more advanced models, this isn't. I guess what this doesn't fit is the fact that it stops increasing too fast. So what is that? What is making that happen? Do you think? Like it should grow more, but they all kind of stop, and then the slow decrease starts. We don't. It's not high enough to have enough people who have immunity, but it still goes down. What are your current thoughts on now that we've seen data about what's going on?
Right. I mean, it's clearly not immunity, but clearly also the lockdowns began happening in March.
Okay, so you think it's the lockdowns, and we're gonna get to Sweden, which is one of the questions from the audience in a second. Okay, so you think the lockdown is what explains, but then that means that it's gonna come back soon, or is it that the weather stops it too? Because if we're gonna get out of lockdown, we don't have the immunity, then the model predicts it's gonna go up again. Am I wrong about that? Yeah. Okay.
Yeah. I mean, I think lockdown is a very broad term.
I see.
And I think the question is whether, and I do think probably weather has some bearing on it. I don't know the magnitude. I mean, we've estimated it for other beta coronaviruses, but I don't know the magnitude of the weather effect, but I think there probably is some. And I think the question is whether we can lift it wasn't just the lockdown at those times. It was the lockdown plus people wearing masks, plus people social distancing when they were having some activity outside the house, etc. So I think the optimistic possibility is that we can remove the most burdensome and least important parts of the lockdown and still keep the epidemic somewhat under control, especially at lower levels where contact tracing can be more effective. I think that's a possibility, but I also think that's not really being carefully done in many parts of the U.S. at least.
Okay.
But that's I think what we're all hoping can happen, at least in the medium term. Whether it's the question.
Let me ask you. This is another one from the audience, which is an interesting point, and I've also wondered about this. Is it possible that maybe we have some other mechanism that makes us immune, some of us, but it's not captured by tests, like the antibody tests don't catch it, right? So that there's more immunity than we realize.
I don't think so, in the sense that the data pretty strongly suggest if you've had documented COVID, then you become positive on the antibody test. So, I mean,
Okay.
one question is what the mechanism of immunity is, whether it's T cells or antibodies or a mix or whatever. But regardless of what you think about that, and my sense as a non-immunologist is that antibodies probably are a very important part of it. But regardless, even if you think antibodies are purely a marker of exposure, there aren't a lot of people out there who have been infected and recovered and don't have antibodies. There probably are a few, but not many.
Okay. Well, but what if they never get it? I don't know. I mean, I guess it's just maybe this is too much speculation. But what I was thinking is you never even get it. It's just there's some mechanism that keeps some group of people protected, and that's why this kind of stops when it stops.
Yeah.
But
I
yeah,
mean,
it's total speculation.
there's
I
been
was
a lot of
wondering.
discussion about the idea of heterogeneity in the population in terms of susceptibility to getting infected. And we've actually done work on that in other settings. It is a potentially real phenomenon.
Okay.
And the models suggest that if people vary a lot in their risk of getting infected because of long-term characteristics, not just like they went to the bar tonight, but if they go to the bar every night, or if they're people who have a weak immune system, or if they are people who just never leave the house, and persist in that over long periods of time, then the herd immunity threshold, the proportion of the population that needs to become immune by infection to slow transmission, is less than what it would be if everyone was the same. And one of the things we're actually trying to do now with collaborators is to estimate how much of an effect that is. I think it probably is a real effect. Some people have suggested it's an enormous effect, like only 15% need to get infected. I think that's probably wrong, but we're trying to figure out how big an effect that might be.
Interesting. No, that's going to come up with some of the other thing I'm going to show you. So this is let me show you one more thing. So here's another observation I've made, which is that if you take New York and the states that are around New York, can you see them down here? That's 50% of the deaths in the U.S. So what is there must be some other factor explaining severity. Maybe it's some super spreader. I don't know. I'll let you comment on what you think it might explain that there's been so many more cases in New York and its surrounding states than other places in the U.S.
Yeah. Well, I think all of those are places with big, dense urban centers and a lot of public transport. And people have been hinting that is important. I think nobody has proven it other than by this sort of ecological argument, but I think it's very reasonable to expect that, maybe less so in Connecticut, but in the other parts, other places, they include dense urban areas. They also include large pockets of very disadvantaged people, and the racial, ethnic, and socioeconomic disparities of this epidemic are now well appreciated, and probably connected in part to the density of populations as well, although that's a hypothesis now, as far as I'm aware, not a fact. So I think, but you could certainly ask, why not Los Angeles, which certainly has had some problems, but maybe not on the same scale as New York, and why not some other relatively dense cities. But I do think density and public transport are likely culprits for part of it, and I think concentration of disadvantage is another likely culprit.
That's one of the audience had a question about that. Yeah.
Yeah. But I think, those are all in the Northeast, and I don't know if those are those the top 5 states from deaths?
No, those are not the top 5. They're just the states that have a border with New York.
Yeah.
The other big ones are Illinois, Louisiana, Michigan.
Yeah.
Those are also
Well,
in terms of rates. Yeah.
Those help those work along with that hypothesis.
Sure. All right, so now there's questions about Sweden. I'm going to show you the data. Right, here you go. So we've heard that, wait, did I share the wrong thing? I think I did.
Share anything.
Okay, weather would like, no, don't. All right, let's see, okay, come on. All right, here we go. All right, so here's what we see that Sweden is way worse than its Nordic country neighbors. You can see it here. This is the same plot I showed you before. But now if I instead show you other neighbors that aren't Nordics, then it's a different story. Like, I don't know if you've seen, Belgium is like the worst, I think, in terms of at its worst, it was the worst hit. But anyways, when you look at this, then Sweden doesn't look that bad, except maybe for the fact that the decline is slower than the other places. Mm-hmm. But I'll show you, let's compare us to them. We have about the same, roughly the same population size. They're a little bit more than us, but in Massachusetts, I mean. And I mean, they're doing better than us. So what is it, what do you have, what are your thoughts on Sweden? Why isn't it worse there? It's because the models say that it should be worse in Massachusetts, I would think.
Yeah.
Given that they didn't lock down.
Well, I think it depends what you mean by the models. I think a simple model that just uses the lockdown, that assumes everything's equal except for the lockdown, mm-hmm. would indeed say that that's the prediction.
I see. Okay.
And I don't know the answer. I think, you know, I'm speculating now, not telling you facts. But one thing is that I think Sweden is a less dense place, including Stockholm, compared to mm-hmm. Boston, I believe. Mm-hmm. The second thing is that income inequality in Sweden is famously at the low end of the scale, and in the U.S. is famously at the high end of the scale. Massachusetts isn't the worst, but is certainly has significant pockets of strong disadvantage, which have been among the very hardest hit. And the third thing I think is that Sweden really there was an awful lot of sort of self-isolation and locking down that was not mandated by the government, and that's mm-hmm. an anecdotal. That's a collection of anecdotes. Larry Summers always said data is not a plural of the anecdote, but but from what I have understood, people are generally, if they can, staying home. There certainly have been pictures of people in bars and doing things that we would say are high risk. So it's not perfect, but I think if I had to guess, those would be my three guesses.
Okay, so good. Now I'll continue on this vein, because one thing that as a statistician is we like to think about what explains variance. Mm-hmm. And there's one here that it's really hard to explain, at least for me. So what I'm going to show you now is this is the total cases by million. So it's so you can see these are the ones that have no cases. Other small places usually. Let me show you the highest ones. There's the ones as you expect. The U.S. is up there. All the states are way up there. But here's a plot that really kind of I can't wrap my head around it. All right. Whoops, what happened there? Sorry. Okay, here it comes.
I don't even do arithmetic in public. I find it amazing that you do RStudio in public.
Well, I already wrote the codes, but here's a histogram. What the heck? Here's a histogram of the total. So this is the total number of deaths divided by the population times a million by countries. It's a histogram. So the red line is what I think is about what the flu does in a bad year. So all these countries to the left of the red line are countries where the flu was actually worse. But then you have these really bad ones on way at the right, which I guess is New York, and I guess Spain, Italy, they're all out there. But you see the variability is immense. Like, what explains this variability? Why is it so much worse in some places than others? So you know, the one explanation that we talked about is maybe weather and density, but is there maybe more to it? Because again, this is a lot of variance that goes without explanation as far as I can tell.
I think I'd have to speculate better. I would have to see what some of the countries on the left-hand side are.
Sure.
But I think
yeah, on the left side, sure.
You can't have COVID deaths without COVID testing, and large parts of the world aren't testing very much.
I see.
Even
Okay.
aren't testing their deaths.
I see.
So I think that's going to be a piece of it.
I see. So eventually we'll have excess mortality.
I would also just want to emphasize, you know, the ones on the right, even we think maybe 10, or in this case of New York State, maybe 20% of the population has had it. So comparing to flu in 1 year is probably about 10 or 20% of the population having it.
Yeah, sure.
But
well, there's no doubt that, let me just be very clear, there's no doubt that this is way worse. That's why that you have these points way out to the right that are could never happen with the flu, but just that there's the fact that some were really bad and some weren't is and so much worse is what I have a hard time understanding how that could be. Like there's some, maybe it's just bad luck that gets multiplied. I mean, there's many potential explanations, but it seems to be lacking in what we know right now.
Yeah.
Like,
well, I think the timing of the takeoff is also relative, and the relative timing of when it took off and when places put in control measures is quite variable. One of the first things we did as a, maybe I'll show my screen for a second if that's helpful.
Sure, of course.
One of the first things we did as a public health tool for to help health departments at their request was to just make a very simple branching process model of what of what might happen under various assumptions about the number of introductions that had occurred and where and what the properties of the epidemic were, because this was all in when April seemed far in the future, so I can't remember when that was. That was I guess that was early February. Can you see this?
Yeah.
So this is a screenshot of this Shiny app that we made, and lots of uncertainty in the parameters, some of which still exists, and this is just illustrative. But this was multiple runs of the same branching process, and the mean is in black, so you can see most of the runs never took off. Some of them took off very early and went exponential. The y-axis is 6,000 cases.
Well, that's very much in agreement with what we're seeing, actually. Interesting. Yeah, because it's showing the same kind of thing. It's kind of low for most, but then every once in a while it just shoots way high.
Yeah, I don't think we're still in that point, because I think every place in the world has been seeded with enough cases so that all the chains haven't died.
No, yeah.
So I don't think we're still in that realm anymore for most countries, but I do think that that under ascertainment is a big piece of it, and I do think that some of it is also probably just if you were a lucky country that had few introductions, or especially few successful introductions in the sense of they seeded chains of transmission, because all of this is very stochastic when the numbers are small, and then the law of large numbers takes over, and a branching process just becomes exponential growth almost deterministically once it's large, as these things show. But back here, there's all this sputtering chains of transmission.
Okay. Interesting. Well, can I then show you one more thing? You have to stop your.
Nope, I'm going to stop you from asking me any more hard questions.
Yeah. Okay. No, this one is in line with what you just described. So here's now what makes me worry. So Brazil. So it starts later, and I'm not going to show it, but you can look it up. I have it here on my screen. But the weather in Brazil, it's in the southern hemisphere. In Sao Paulo, it starts getting cold in May, colder. And then you also see it in Peru, but then some of the other places that are closer to to the equator, like my hometown and the Dominican Republic, it's not, you don't see the same thing, right? So I see this and I think, well, when it gets cold in Massachusetts again, I don't see any reason why this won't happen. But maybe I'm being too pessimistic. I don't know what you have to say about that one.
I think it's a real risk.
If you want me to leave it up. But yeah, the point is that Brazil got cold. Yeah. Oh.
I think it's a real risk. I don't think it's just that Brazil got cold. I think it's also that it started to take off. And you know, maybe they just were one of those lucky jurisdictions that didn't have a big seeding that was successful. But I think, I mean, our estimates, for what it's worth, from the other beta coronaviruses are that seasonality changes the reproduction number about 20%, the trough minus peak over peak.
So it gets lower.
Yes. So in the summer, the peak is actually, it's not at the height of winter. The peak of transmissibility is around November, by our estimates from the seasonal coronaviruses in the US. And the trough is about 6 months later, using a spline, so it's not forced to be, but it's roughly 6 months later. And the magnitude, the amplitude is about 20% of the peak down to the trough. Other groups have done analyses. Mauricio Santillana here in Children's Hospital and Tama Carlton in Chicago have done analyses with COVID data, which is more relevant but less high quality than the beta coronavirus data that we analyzed. And they get kind of similar orders of magnitude, 20%-ish. So it's not enough to make the summer a totally safe time, but it is enough to make the summer a less bad time.
Okay. So I'll ask you a question from the audience and related to this. So let's suppose that seems like we should be getting ready for a second wave. What should we do differently this time? I think you answered part of that earlier, but I'll let you summarize it now towards the end of the seminar.
Yeah, I think, I mean, clearly one thing we have to do is protect congregate settings, nursing homes, jails, prisons. Almost all the biggest outbreaks have been and many of the deaths, a high proportion of the deaths have been in nursing homes, but also in jails and prisons and slaughterhouses. We don't have any of those in Massachusetts, I don't think, at least large ones. So I think we have to stop, as best we can, stop these really high risk concentrations of high risk people very close to one another from transmitting. And I don't know how to do that, but I think that's got to be a very high priority. That will bring the death rate down, even if the epidemic is as bad as it otherwise would be in terms of cases. I think the next thing is we have to figure out what can be reopened more safely, because I think it's just not going to be the case that people will tolerate a year of economic and social stasis.
And one of the questions was, are we going to open schools?
Yeah, I don't know the answer to that. I think people are trying to figure out what the data say. I think the data on young kids increasingly show that they are less risky as sources of infection than people who are older. Maybe they shed less virus, and they seem a little bit less likely to get infected. Whether that's enough in the presence of schools to mean that it's safe, you know, whether that's enough to mean that it's safe to reopen schools, maybe at lower density and maybe with half the people online or something at certain ages. I think it's just going to be an experiment to see. And Sweden has done the experiment. Hopefully more data will come from Sweden. A few other places have done experiments like that, and maybe we'll get data from summer camps, although a lot of that's outdoors. So I think the most important thing is going to be to try to learn lessons about how we can sort of soothe the most acute unpleasantness that the lockdown causes, while minimizing transmission. And I think there are a lot of sort of individually probably small but collectively maybe effective things. Wearing masks, I think, is probably the biggest. I think we're going to all be wearing masks for a long time. I think things like paid sick leave, and not just sick leave, but also an obligation to take it if you're sick. So I know even some hospitals that I've visited for my own care before things got really bad, didn't have paid sick leave for all their employees, and that just can't happen in a healthcare setting, especially, but anywhere. I think doing a better job of ventilating buildings will make a difference.
Maybe turn off the AC if we find out it's the heat helps.
Yeah, well, we'll see. Yeah, I mean, so I think there are a number of those things that we just haven't done before. Each one of them, if they make, a few percentage points difference in the reproduction number, will add up. And I'm not saying that will solve the problem, but every bit that we reduce the reproduction number will make it less catastrophic if we do have a second wave. So I think we have to try all of those things and try to really learn from what other places have found.
Excellent. Well, thanks. That was really great. We learned a lot, and I'm going to let you finish with any message that you have for all the data scientists that are listening. And is there anything that you think they can do to help, or what they should? Is there any advice you have for anybody that wants to get involved or in the future become an infectious disease epidemiologist?
Yeah, I mean, I think I'll refer you to the article I wrote in the Boston Review a few weeks ago, which sort of says what I think on the topic, and I'll put that up here if I can do it. I think, as I said at the beginning, there's data and there's data, and infectious disease data is really interesting and really fun to work with, in part because there's so many puzzles about how to make sense of it. And someone like Mauricio Santillana is someone I really admire, who's a data scientist trained in physics and from a different direction, but has really embraced the challenge of trying to use data not as if it's given by a sort of reliable reporting system, but as a challenge to understand what is the noise, what is the signal around all this noise, or inside all this noise. I think as I said at the beginning, I think the people who do really good work on infectious disease, especially in outbreaks where the surveillance system is literally being built as the epidemic unfolds, and so it's like trying to predict weather while each county is inventing a new thermometer every day. It's a challenge. It's fun. It's hard. But if you embrace that as the challenge rather than trying to do a better maximum likelihood fit to shitty data, so seeing where the big problems are and trying to solve them, I think is really what makes all the science around infectious disease epidemiology better.
All right. Well, great. Thanks, Mark. Really great. And we'll be in touch. Thanks again for doing this.
All right. Thanks, Rafa.
Bye-bye. Bye, everybody. I hope you enjoyed it.